Welcome back to Medical Rocket. I am so excited to dive into today's topic with you because it's one of those things that just clicks once you understand it, and it's super high yield for all your exams. We're talking about extrapyramidal disorders, with a major spotlight on Parkinsonism. Let's get into it. So, what even are extrapyramidal disorders? Think of your brain as having a couple of major highway systems for movement. You've got your pyramidal system, which is like the direct express lane from your brain to your muscles. But then you've got the extrapyramidal system, which is more like the control center for fine-tuning movement, making it smooth and coordinated. It's all about the basal ganglia and its intricate connections. When that system goes wonky, that's an extrapyramidal disorder. Now, within that big umbrella, we have Parkinsonism. This isn't a specific disease. It's a clinical syndrome. What does that mean? It's a collection of symptoms. And the absolute core symptom you must remember for Parkinsonism is bradykinesia. That's just a fancy word for slowness of movement. Not weakness, just slow. And you need at least one of these buddies along with it: a resting tremor, rigidity, or postural instability. If you see those, you're thinking Parkinsonism. But then there's the classic one, the one everyone thinks of, Parkinson's disease, or PD. This is the OG. The cause here, this is a huge board question, friends. It's the loss of dopaminergic neurons in a very specific spot called the substantia nigra pars compacta. Dopamine, dopamine, dopamine. And the core symptoms of PD, bradykinesia, like we said. Imagine trying to button a shirt and your hands just aren't cooperating. A resting tremor. This is super characteristic, often described as pill rolling. It's like they're rolling a tiny pill between their thumb and finger. And here's the trick. It gets better when they actually try to do something. Rigidity. It's not just stiffness. It's often cogwheel rigidity, like a ratcheting feeling when you try to move their limb. And postural instability. They lose their balance easily. They're prone to falls. Beyond those core motor symptoms, what else might you see? That characteristic shuffling gait, a mask-like face called hypomimia, where they just don't express emotions easily, a soft voice, hypophonia, and their handwriting gets tiny, micrographia. But listen up, future docs. Don't forget the non-motor symptoms. These are often the first things patients notice, sometimes years before motor symptoms. Things like depression, losing their sense of smell, anosmia, chronic constipation, REM sleep behavior disorder, and unfortunately, in late stages, dementia. These are super important for a holistic view. Now let's talk about the tricky ones. Parkinson plus syndromes. These are the atypical Parkinsonisms, and they love to show up on exams to trip you up. What makes them different? Think MSA, multiple system atrophy. If you see Parkinsonism, but the patient also has severe autonomic dysfunction, like orthostatic hypotension, where their blood pressure drops when they stand, or urinary incontinence, and sometimes cerebellar signs like poor coordination. That's MSA. Then there's PSP, progressive supranuclear palsy. The absolute key here is early postural instability. They're falling all the time, and crucially, a vertical gaze palsy. They just can't look up or down properly. Axial rigidity is also a hallmark. Corticobasal degeneration often presents with symptoms that are super asymmetrical. One side is way worse than the other. You might also see apraxia. They just can't do learned movements, like combing their hair. And the weirdest one, alien limb, where an arm or leg feels like it has a mind of its own. Seriously unsettling. And finally, a huge one for boards, DLB, dementia with Lewy bodies. This is where the cognitive decline, the dementia, happens early, often before or at the same time as the Parkinsonism. Plus, they have recurrent, vivid visual hallucinations, and their attention fluctuates wildly. Remember that combo: dementia, hallucinations, fluctuating attention. Okay, let's switch gears to secondary Parkinsonism. This means Parkinsonism that isn't due to classic PD, but something else causing those symptoms. What causes it? The biggest culprit for your exams: drugs, especially antipsychotics like haloperidol or risperidone, and the anti-nausea drug metoclopramide. Why? Because they block dopamine receptors. That's literally taking away what PD patients already lack. Other causes include vascular issues, small strokes in the basal ganglia, infections like HIV, toxins like manganese, and repeated head injuries like pugilistic Parkinsonism you see in boxers. Poor guys. How do we diagnose this stuff? It's mostly good old clinical diagnosis, a thorough history, and a careful physical exam. We're talking detective work here. MRI is often done to rule out other things like a stroke or hydrocephalus. DAT-SPECT scans can be pretty useful. They can help us differentiate classic Parkinson's from essential tremor or some of the atypical Parkinsonian syndromes. If the DAT-SPECT is normal, it's generally not classic PD. And here's a massive pearl. If a patient has a poor levodopa response, meaning they don't get much better with the main drug, it strongly suggests atypical Parkinsonism. Classic PD usually loves levodopa. All right, treatment. What do we do for these patients? The undisputed champion, levodopa, usually given with carbidopa. Carbidopa just helps more of that good stuff get to the brain by inhibiting its breakdown outside the brain. It's truly the most effective. Dopamine agonists, like pramipexole, ropinirole, we often use these in younger patients to try and delay some of the motor complications that can come from long-term levodopa. MAO-B inhibitors, like selegiline, rasagiline, can be used in earlier stages of the disease.